Hello, everyone. Thank you for joining me for my honors project presentation. I researched a genetic eye disorder called Aniridia and assessed eye care development of third world countries and their ability to respond to diseases like Aniridia. Before the details of Aniridia are discussed, I want to give a brief overview of the anatomy of the eye to understand which structures are affected. Aniridia is generally known as the absence of an iris. The iris is the colored portion of the eye here, responsible for constriction and dilation of the pupil. This regulates the amount of light able to enter the eye and strike the retina, allowing the visual process to occur. Without an iris, the pupil size is not regulated. Its visual acuity decreases, and there's a severe sensitivity to light. Other structures can be affected, including the cornea, which is this transparent external region here, and the lens. These are responsible for focusing light to the retina, which is this back portion here. The macula is a region of photoreceptors responsible for central vision and color vision, which can be displaced. And the optic nerve relays the signals the eye receives to the brain to understand what is being seen. Aniridia is characterized as the presence of an abnormal iris, varying from complete absence, a rudimentary iris stump, to a nearly complete yet thin iris. This is genetically inherited, which can be associated with other ocular disorders, including cataracts, glaucoma, nystagmus, hypoplasia, and keratopathy. Cataracts is the gradual clouding of the lens, decreasing visual acuity. Glaucoma is increased intraocular pressure, which can damage the optic nerve. Nystagmus is a lazy eye, so this is involuntary movements of the eye affecting coordination and balance. Hypoplasia is displacement of normal anatomy, and this can happen to the optic nerve, the macula, or the fovea. And keratopathy is the breakdown of the corneal epithelium, leading to irritation and other complications. The current frequency of aniridia is about 1 in 40,000 to 100,000 people. This is a relatively rare disorder. This first image here is an example of aniridia in a patient. The eye looks mostly black due to the lack of iris. However, here you can see a sliver of brown, which would be considered the iris stump. This second case here is not aniridia, but it is an example of a cataract, the clouding lens, and of keratopathy, but that's hard to be discerned in this image. Aniridia is inherited genetically. About 2/3 of the affected population inherit this through autosomal dominant pattern. That's explained here on the left. This male is affected. It has one mutated copy and one normal copy of the gene that causes aniridia, and this female is unaffected. So upon meiosis, to form the gametes, these chromatids will split, and this affected copy will go into 2 of them, and this unaffected copy will go to the other 2. And that explains why there's a 50-50 split of affected children. These 2 received one copy of the mutated gene. That's why it's known as dominant. Only one copy is needed. These 2 children are unaffected because they received the normal version from both parents. And this Punnett square is affirming what that picture shows, that these 2 alleles, one is dominant and one is not. It's passed down to 2 children, and this unaffected gene is passed down to the other 2, not resulting in any disorder. The other 1/3 of the affected population of aniridia is caused by sporadic mutation, and this is caused when there's an unequal crossover of chromosomes during meiosis, leading to gene duplication or recombination, and this will alter the traits that are inherited. The key genes here are PAX6 and ELT4. The second is a regulator of PAX6, so if that's dysregulated, so is PAX6. And WT1 is also notable because it causes Wagner syndrome, which will be explained in a moment. This is a table of all the known genes that are associated to be dysregulated with aniridia. So the 3 previously mentioned are highlighted in black. We're not going to go through all of them, but generally speaking, any mutation in these genes leads to the improper function of various regions of the eye during development, as the disorders will result from those. They're all associated because the PAX6 alteration will affect the genes around it, leading to these different types of disorders. Either they include aniridia or they're similar to it. Notable disorders that are associated are Wagner syndrome, Wagner syndrome, and aniridia-associated keratopathy. Wagner syndrome is a defective anterior segment, which was cornea to the lens, and this is thin or perforated iris tissue, reducing its proper function. And this is inherited in an autosomal dominant pattern, just like aniridia. This bottom image here is an example of Reiger syndrome. There are multiple holes in the iris here, looking like multiple pupils, which affects the amount of light and where it is able to strike the retina, decreasing vision significantly. Weiger syndrome stands for Wilms tumor, aniridia, genitourinary, and mental disability syndrome. And it results from partial deletion of the WT1 gene on chromosome 11. This affects multiple organ systems, not just the eye, and this making it a very severe syndrome. AAK is a cornea malformation causing repetitive irritation and infections, which is riskier to the patient and it's more difficult to treat. And studies show that up to 90% of aniridia patients have this compounding disorder affecting their treatment. There is good news for this disease. There are treatments, and largely it's in the form of an implant. So before this can be done, preoperative planning is essential. So there are different types of eyes known as aphakic, pseudophakic, and phakic eyes. So aphakic is without a lens, pseudophakic is a false lens, and the phakic is the natural lens. There was nothing wrong with that patient's lens. There's also the color matching process. This top image is an example of the different types of color matching a particular implant is able to have. There's also a patient history that is important to consider for the surgery and the recovery plan, as well as some certain measurements that need to be taken by the ophthalmologist. The surgical option includes a couple different implants that are being used all over the world. A few to highlight: the new iris. It has limited use because it is a rigid implant that utilizes a large incision site. And so this is riskier and could lead to infection or longer healing times. It also does not have the ability to be color matched. It is black. And so this can be startling to the patient, as one eye is their original color and one still looks like it's lacking the iris. However, it is functional and it will increase vision significantly. It also requires a partial iris to be present for attachment, and this can be difficult since not all patients present with this. The custom flex human optics artificial iris is much more versatile and adaptable because it is a more flexible implant and can use a smaller incision site. This implant can be color matched, which is better for patient outcomes, and it can be attached to multiple sites, including the sclera, the anterior segment, and the posterior segment of the eye. An intraocular lens or IOL implants are often used in conjunction with these, since compounding disorders like cataracts will affect the lens. Those will need to be removed and a replacement will be put in during this surgery. Postoperative care is just as essential for infection prevention, as well as monitoring intraocular pressure to make sure glaucomas do not form and damage the progress that was just made. These are two examples of a corrective surgery with an implant. In this patient here, the implant was placed in the left eye. It was color matched to the patient and an intraocular lens was placed. It looks almost identical and it improved this patient's vision. This is the custom flex artificial iris. Here we have a different brand of implant, which was more functional than it was cosmetically advantageous. But you can see that a cataract was corrected. Here it's cloudy, and here there's an intraocular lens, and this artificial iris was placed, improving this patient's vision. In addition to researching the disease, I interviewed several ophthalmologists from all over the world to see if they've ever seen aniridia and how they're able to respond to this disease and the associated disorders. So these countries included Eswatini, Kenya, and Burundi. These are all African nations, and Papua New Guinea, which is a Pacific island country. These were highlighted because of the preventable blindness in the world. 19% is in Africa, and this is largely due to untreated cataracts. The cataract surgery rate in Africa is currently the lowest, and this highlights the need that they have for eye care development. Upon my interviews, I learned of several obstacles that these countries face, being the physician number is significantly smaller than the patient population needing treatment. This is due to the lack of specialization in these countries. There are just fewer doctors that are ophthalmologists that are able to perform these surgeries, and there's just a very large demand that can't compete. There are fewer treatment locations because hospitals are generally localized to bigger cities, and so those from smaller villages have to travel a really far way, and this is often not something that they're able to do. There's inconsistent or limited resources. Most resources are outsourced from other countries, so depending on the time of year, they may not be able to access them, or they may run out quicker or slower than they were expecting to, and this increases the wait time for patients, and this decreases satisfaction and the quality of life while they're waiting. There's limited healthcare professional education, just fewer opportunities to be trained, especially in the specialized forms of ophthalmology, which contributes to the small physician number. And then finances for the patient, paying for the surgery, paying for transport, recovery time, missing work, all of these all play into whether patients are able to receive treatments or not. A couple current global eye care initiatives I looked into that are focused on eye care include Orbis, which is a flying eye hospital, which is here in this top image, and this is one of their ORs on the aircraft in that bottom image. So they're able to virtually travel to anywhere in the country and set up, and they're able to treat as many patients as they can while they're there. They have a special technology called CyberSight, which is a telehealth platform that allows doctors to coach their surgeons through new procedures, as well as meet one-on-one with patients, allowing more patients to be seen otherwise, even though those doctors are not physically present. They also focus on ophthalmology education so that more doctors in these underreached regions can specialize. The Himalayan Cataract Project focuses on cataracts. They've also provide cornea transplants, but their emphasis is on training fellowships for those local doctors who maybe need specialization or to train other doctors to provide these minor procedures in those areas, making it a very sustainable program. The Luke Commission is an organization that MVNU partners with. They're a very general and broad outreach program. However, they're able to provide general eye exams and reading glasses in every village that they visit. They have a unique program called Eye Week that I also wanted to highlight. So Eye Week in Eswatini is when they host international physicians for about 2 weeks, and they perform a very high number of ocular surgeries. Most of these surgeries are cataracts, contributing to the resolution of that low cataract rate that was mentioned earlier. They're also able to successfully complete corneal transplants, which was huge advancements for them and for the country of Eswatini. But TLC, while these surgeons are here, they take care of all pre-op and post-op. So patient history, transporting the patients to the Miracle campus, getting them set up, as well as medications afterwards, transporting home, and a place to stay for recovery on the Miracle campus. And this is all free of charge to the patients, allowing the largest number of people to be seen. They're able to see hundreds and hundreds of patients in just these 2 weeks while these doctors are here. So through my research and my interviews, in order to address some of the obstacles, early intervention is key. Aniridia and some of the associated disorders will show up in infants and young children, but they're not able to articulate what is wrong or what they're experiencing. So educating parents on the signs and symptoms is extremely important to get treatment sooner. Otherwise, the eye will not be able to develop properly and they will not see properly for the rest of their lives. It's also important to intervene in the adult and elderly populations, especially in circumstances like cataracts and glaucoma, because those symptoms are reversible up to a point. And so recognizing when it's time to receive treatment and getting them to those places is important to correct that vision and improve their quality of life before it's too late to do so. Pro bono surgery will always be beneficial to lighten the burden that physicians in the area are facing for the very high demand for the surgeries, but a very low supply of resources in their time. But overall, a long-term on-the-ground mission organization is a key way to address the great need for eye care in these harder to reach regions. This can be done through creating sustainable eye care programs through good education, educating the public on when to be treated, and educating healthcare professionals and ophthalmologists in these regions so they can continue to train and allows an expansion of where treatment can be obtained for the patients. Improving infrastructure is important, potentially expanding on current hospitals or building smaller outpatient buildings closer to the villages to reduce transport obstacles. Better resources or just better timing of obtaining these resources and training are all essential for these organizations in meeting the needs of these patients. I wanted to give a special thank you to my advisor, Dr. Carrie Beal, to my readers, Dr. Fuller and Dr. Christina Jones, to Dr. Wiley, the Honors Program Director, for all support over the several years that we've worked on this, as well as the Smelzenbachs from TLC, Jim Radcliffe, and the other missionary doctors I will leave unnamed just for their safety, but who all responded to my interviews and gave such great insight into this issue. Just briefly, my interviews, if you are interested in seeing more or reading the full account of what these physicians see, I have provided a link to a Google Doc here that you're able to read each of the interviews from the doctors and all the research that I compiled from them. So thank you so much for your time. And at this point, I would take any questions. Thank you all so much.